Good day to one and all. Hearty welcome to each one of you today to the third session from the learnings from from ADA. This is a series of knowledge sharing sessions planned to benefit anyone who did not get the opportunity to be physically present at the most recent ADA conference that was concluded last week. We have an interesting lineup of topics and speakers today. And to introduce the entire panel, I welcome Dr. Amit Gupta. Sir, over to you.
Thank you, Uma. And as you know, this is the third day for learning from the ADA. And as the whole concept of this program is that to bring you whatever was being discussed at the recent 84th scientific session. I welcome all of you on behalf of Diabetes India and IDF Southeast Asia. I would like to acknowledge the contribution of Dr. Azad Khan, who is currently the chair of IDF Southeast Asia, Dr. S.R. Arvind, President of Diabetes India, and Dr. Bansi Sabu, the Secretary of Diabetes India, and myself, I'm the Joint Secretary of Diabetes India. So we welcome you for this third day of our webinar and continuous activity. And today we have a very esteemed panel with us. We have Dr. Peter Swartz, and Dr. Peter Swartz, you all know he doesn't require any introduction in our part of the world because he is coming and obliging us so frequently to India that and we get the chance to learn from him and learn from his expertise. So Dr. Peter Swartz is currently the Professor of Internal Medicine and Head of the Department of Prevention and Care of Diabetes at the Technical University of Dresden. He is currently the Chair-elect of IDF Southeast Asia. And Dr. Peter Swartz has many awards to his credits, and he has contributed to the academia in a substantial way. More than 344 papers in peer-reviewed journals and contributed chapters to various textbooks. And he has a very, he's actually committed to improve the diabetes care all across the globe, and he has a passion for diabetes education. So we welcome Dr. Peter Swartz. Another speaker we have is Dr. Sanjay Agarwal. And Dr. Sanjay Agarwal is Honorary Secretary of RSSDI. And also, Dr. Sanjay Agarwal is a very illustrious. He has a very illustrious career, and he has taken RSSDI to new heights. We all know he has contributed in a substantial and significant way in the development of the RSSDI and taking RSSDI to the global platform. And to moderate this entire program today, we have none other than Dr. Abhay Sahu. We all know that Dr. Abhay Sahu was the organizing secretary of recently concluded Diabetes India 2024 at Bhubaneswar, and under his leadership, we saw a very, very big conference happening. And he is an endocrinologist based in Odisha, Bhubaneswar, working attached with Apollo Hospital and Apollo Sugars. And he has contributed to academia by means of several peer-reviewed articles, journals, topics to chapters or textbooks. So welcome, Dr. Abhay Sahu, and I leave it to you from here to conduct this session.
Yeah, thank you, Dr. Amit, and thank you to all the respected dignitaries for today's meeting, where we are going to discuss the things which has been actually discussed in ADA this year. But now a lot of people from India did not attend that. And this is the opportunity where we can actually get the knowledge from the esteemed speakers, and they will definitely enlighten us with their with these topics or subjects what we are going to discuss. And our first speaker, Dr. Peter Swartz, is already Dr. Amit has already introduced himself, and I would request Dr. Peter to kindly start his presentation. Then any questions, anything, please, I will request all our audiences, please put in the chat box, then so that we can discuss subsequently in the last part of our discussion. And all our speakers and chairpersons definitely try to get all the queries and also try to answer all the queries. And the first part is innovation in diabetes prevention and potential for global scale. And here Dr. Swartz is going to discuss that part. And now up to Dr. Swartz for his presentation.
Namaste. Dear Dr. Abhay Sahu, dear Dr. Amit Gupta, thank you very much for the introduction. And I must say, it's totally cool what you are doing here. For those colleagues from India who had not the chance to attend the ADA, to summarize what was discussed on the ADA, and by this helping to educate our medical workforce for people with diabetes, and always to stay up to date and on the current evidence what is existing. I would like to take the next 25 minutes to talk about some new ideas which were intensively discussed at the ADA, not only in the sessions, also between the people. For some of the sessions, they had made video streams and had interviewed the speakers afterwards, and to summarize again. And these aspects I would like to touch a little bit. Thanks to Amit Gupta, who has already introduced me, but I'm not the chair-elect of the IDF Southeast Asia. I'm the chair-elect of the International Diabetes Federation, so will become the president in April 25 of the whole IDF 7 regions. And I think this is a very satisfying chance really to do something to have an impact on the global scale for people with diabetes. And for me, this means improving the quality of care. So I have a deep passion and a lot of energy for doing whatever is needed to help to improve policy, improve care delivery, accessibility, availability of diabetes care. And this is what I would like to achieve during my presidency ship. I just see that Amit has opened the video again. Dr. Amit, do you want to say something?
No, sir. I would just like to acknowledge and thank you for always giving your continuous support to Diabetes India and all the IDF members of the IDF Southeast Asia. Thank you, sir. Please proceed.
Yeah, there's absolutely no reason to thank, because if I look on the global scale and want to put my finger on this country where the most activity in the diabetes care, it's India. And I actually have to thank you for having such an enthusiasm, such an energy, such a passion for doing activities like you just do. And not only this, multiple more on different levels. At the end, always focusing on improving care for people with diabetes. So a big thank from my side and from the side of IDF to you that you are so active. But with this, let's jump in. One topic which was discussed at the ADA intensively was, where is diabetes coming from? What are the health determinants for diabetes? And if you are looking at this slide, you see the number of people with diabetes globally in 1980. The blue bar or triangle is the increase in number of people with diabetes due to the increase in population. This is mainly also India. But the rosé and the yellow one is the increase due to the change of our lifestyle. And if you look into the increase, the absolute increase, it's 70% related to the change of our lifestyle. And also in India. In India, where there is a population who's mostly vegetarian, where we actually would say, yeah, this is healthy. There's no diabetes risk. But also a population where the lifestyle has changed a lot. And some of the aspects which were discussed is fried carbs, which are consumed a lot, especially in India. And several sessions in the ADA touched this. So we have to understand health determinants, and there's also something new. And if you look at this map, you may say this is the increase in prevalence of diabetes. It is not. It is the air pollution, the increase in air pollution over the past 10 years. And this is strongly related to type 2 diabetes. So frankly spoken, if you stay behind a diesel car and you take 5 deep breaths, you can find the medium-sized particles out of the diesel engine 2 weeks later in your beta cell. Is this doing something with the beta cell? We don't know. There are no studies yet, but in cell culture, it does. It has a potential to destroy, not to destroy the beta cell, but to impair function of the beta cell. So air pollution and climate becomes a new determinant for diabetes. And if you are looking why our people are dying, yeah, it's metabolic risk factors and climate risk factors. So if you think about new policies, we have to have this in mind. Diabetes is a communicator or the catalyst for morbidity and mortality in our population. But we are physicians. We have to understand the pathophysiology. And this, what you see here, is healthy. Even I was in Kochi 5 weeks ago at the DTechCon meeting, and for me it was one of the most enlightening tech conferences in the diabetes sector. And there were many sensors and the use of CGM and RT-CGM discussed. But one of the learnings from having these sensors available is this curve, because we learned that healthy means something different than what we thought in the past. This is a young woman, high normal A1C. She's snacking the whole day, but she has a totally flat glucose curve. And this is healthy. This person is very insulin sensitive. She doesn't need, or she needs maybe 1% of the insulin the pancreas can produce to regulate blood sugar, because she's very sensitive to insulin. Compared to her father, it's also truly her father having a better A1C, but a totally different curve. And why I'm showing this? Because today we know that this fluctuation of glucose, especially here, which was maybe breakfast and lunch, and this fluctuation, they are the driver of morbidity and mortality for our diabetes patient. Imagine two people with A1C of 7, one has mild fluctuation, the other one has big fluctuation. The one with the big fluctuation dies because of a stroke or a heart attack. So from a therapeutic position, what we have to do, and it is the same for prevention and care, we have to reduce fluctuation. We have to basically do this to improve the outcome for our diabetes patient. The question is how? Yeah, one ideal drug to reduce fluctuations, metformin and DPP-4. Sulfonylurea increase the fluctuation. Also, insulin is unfortunately increasing the fluctuation, generating more hyporisk. The sensors with pre-alarms, they are very beneficial because the patient can avoid getting a hypo. But if they overreact, it also increases fluctuation. So avoiding fluctuation of glucose becomes one of the challenges in the future. If we go into the diabetes pathophysiology deeper in, the main driver, and this is also India, is the visceral fat, is the ectopic fat, which has an endocrine function producing more than 800 known hormones. And probably if I say 800, the number is already too low. So more than 800 hormones, and they act on all tissues in the brain, everywhere, in the liver, in the kidney, and most commonly they increase our risk of metabolic syndrome. But there is a hot candidate, and this is the hepatic fat. And I don't say NASH or NAFLD and not MASH or MAFLD. I purely say liver fat because we are talking about amounts of liver fat from maybe at 100 grams. So this is something you even cannot see with an ultrasound. You only can see it with MR spectroscopy. And this liver fat you see in the pathophysiology of diabetes development shortly before 100% insulin resistant. If the pro-insulin resistance comes up, liver fat accumulates. But before this happens, so this seems to be one of the main driver of fast development of insulin resistance. This is relevant for India. And then it's continuously going up. Here diabetes starts and here we diagnose diabetes. So we come far too late if we diagnose diabetes to have an impact on the pathophysiology of the disease. The thinking about prevention means thinking to tackle the pathophysiology of the disease in this clinical paradigm. So the interplay between visceral fat and hepatic fat, this is what is getting our patients becoming diabetes mellitus, and this is relevant for India. Here the insulin signal transduction cascade, insulin docks to the receptor, all these white spots get phosphorylated, and then the GLUT4 receptor is translocated to the cell membrane and allows the influx of glucose. The red substances come out of the visceral fat, and they are the common soil for many diseases. Also something like dementia, also something like depression, due to the hormones secreted out of the visceral fat. But there is the other candidate, the hepatic fat, and here is written NAFLD now as a synonym of liver fat. But we switch to this one, and I apologize for the German slide. If you compare people without liver fat and those with liver fat, and then select slim and obese, and here's the insulin resistance written down. Yeah? An obese person without liver fat has a better insulin sensitivity than a slim person, but with liver fat. And this has the potential to change our views on diabetes because the pure presence of liver fat makes the situation worse. And for example, makes you becoming a non-responder for physical activity. 100 grams of fat in the liver makes you becoming a non-responder of physical activity. And this was also shown by Taylor, and this was discussed a lot at the ADA from various sources, also criticized. And so a lot of liver fat means a lot of pancreatic fat, and this destroys beta cell function, but also the opposite works. Removing the liver fat will remove pancreatic fat, and this will restore or has a potential to restore beta cell function. And this may lead to a remission of diabetes. And if I jump back, remission of diabetes, I think, is a new goal, especially not only in Western world, especially in countries like India, Pakistan, but also Bangladesh and China. With the fast development of diabetes, if you can lead to a remission of diabetes, would be a very cool goal or objective. And the only way which is possible today to lead to a complete abolishment of liver fat, so a complete abolishment of liver fat, is fasting. If you fast for 2 weeks without getting any kilocalorie, and every one of you who is now saying this is impossible, it is not. It's a challenge, but it's easy to accomplish. So 2 weeks, no kilocalorie, basically water diet. Thanks to the glucagon, the stepbrother of insulin, the glucagon switches on beta oxidation of fatty acids in the liver and in the pancreas, and by this removing the fat out of the liver and the pancreas. But where is it coming from? Here a slide, 380,000 patient years. What should you drink to get diabetes? If you have 1 drink per day for a year, if you drink water, it does not increase your diabetes risk. Orange juice, especially industrialized prepared orange juice, 40% per year. Coke, 40% per year. But Diet Coke or Coca-Cola Light or any kind of the light products, 60%. How can this happen? The answer is artificial sweetener. And they changed the microbiome. And this was also a hot topic at the ADA, what the relevance the microbiome has. And why I'm showing this here. So now assume you eat a lot of artificial sweetener, or you want to stay healthy and you drink Diet Coke. It changes the microbiome. So there are 14 different bacteria invading your gut. And the bacteria help to digest. So they are not the problem, but they produce metabolites. So basically as their stool, and the metabolites are heavily saturated fatty acids, and they get accumulated in the liver. And so the people become non-responder to physical activity. This is a disaster. But another topic in several sessions was behavior. And I hear that you already heard yesterday several things about behavior. And we always believe if we tell the patient to change, he will do it. And this is not true. Our behavior is an intuitive, emotional process. It is different if the patient has cancer or pneumonia. Yeah? The patient follows our advice. If you talk about diabetes and obesity, we can advise the patient, and he also will trust us. But there are others who are better, and this is a peer group of the patient. So the lifestyle of the peer group of the patient is more relevant to the lifestyle of the patient than talking to us. We can feel sad about this, but this is the truth. And accepting this will help us to develop new ways of behavior change. And this behavior change works always in the same way. There are different stages of motivation, action, and maintenance. If we understand this and use techniques to help the patient to guide this through, this basically could be transformed into modern diabetes education. And this is one of the next challenges which were discussed at the ADA. And a lot were touching smart health and mobile phones, and digitalization, artificial intelligence. And the reason why this is so effective, because you may be able to address need of the patient. And one of the goals I have as the next president of the International Diabetes Federation, I want that the IDF is in the pocket of every diabetes patient in the world. So using smartphone-based app or other application, and mainly focusing on diabetes education for those people. But why can digitalization work? Here you see how how oral agents lower A1C, how lifestyle is lowering A1C, and how digital tools lower A1C, young, old, medium old, and young digital tools. And what are young digital tools? These are smartphone-based apps. So now you can say, how can a smartphone-based app lower A1C? My answer is we are in the pocket of our patient. We never have been so close to our patient than in the pocket of the patient. And this changes our approach. This changes our opportunity to reach the patient. But we also have to change. If we now think in our traditional way how to deliver healthcare, but in the pocket, we will fail. We have to see our patient more as a consumer for lifestyle intervention and use the smartphone as a hub or delivery channel for lifestyle education and lifestyle change. Every one of us is taking 1,800 decisions a day. 450 are related to lifestyle. If we are only able to, with the right motivational strategy, with the right content, in the right moment, to set impulses by the smartphone to influence only 10 out of the 450 lifestyle-related decisions a day, but over a year continuously, we can translate this in 10 kilograms of weight reduction. So modern diabetology can look like this, and we should not fear this. It will be of the benefit to our patient. And there are examples from Germany. Germany in the moment is very much ahead in licensing digital therapeutics in the diabetes sector. Vitadio is one. It's a type 2 diabetes educational application for the people continuously helping them over 1 year. So basically between the physician visit, using AI where you can make a photo of your food, and this information is used to help you to develop a healthier diet. And it works. Over the period of 3 months, people save 470 kilocalories a day. Una is another application using the sensors in doing nutritional coaching by using strategies of cognitive behavior change, using the sensor reading. So the sensor reading is used to help the patient to change diet, and then he is immediately getting a feedback how it works. And One to Diga is a Swedish application, fully based on AI, and a smart cohort of 1,000 patients using a sensor, tracking their lifestyle. And the patient by this app is getting a clear recommendation in 6 areas of diabetes care, what to do. And for example, the app tells them today at 6:35, you should inject 22 units of long-acting insulin. And the multi-language model, neural network, and open language models based technology is analyzing the sensor curve and then making a recommendation to the patient, as I said, what to do, how to correct, how to change lifestyle. But if we think even more ahead, what will be the future in diabetes care? If I would stay in front of you, I would say, what is the best way to diagnose diabetes? And probably you would say it's testing for glucose or A1C. It is not. It is the shopping behavior at Amazon or any other global shopping giant. And there are interesting studies showing that your shopping behavior can help you to identify the start of hyperglycemia 3 months before hyperglycemia, depression 4 months before depression. And this is very interesting. And of course, now we say, no, we cannot do this. It should be in our hand. We should diagnose diabetes. But I think in the upcoming years, we will be in an ethical discussion why we are not using this kind of digital biomarkers. And I think we have to prepare ourselves. And tracking digital biomarkers can be a very valuable source of getting to know about patients, patient behavior, new patient, new risk development. And it can help us to translate this knowledge using digital therapeutics or digital preventive measures in improving health for our people with diabetes or those at risk. So assuming we use smartphones and wearables, we use the data and analyze the data on the smartphone. We even don't have to think about cloud services. Visualize this back to the patient. This is something everyone would be totally agree. If you then say, okay, we use this to prevent diabetes, I think still everyone would be agree. But the next step would be diabetes education. So why not using this information to develop a global strategy of diabetes education by using digital tools or digital hubs. And if we accept this, it's only a very little step also to therapy. If we talk about Rwanda, there are 380,000 people with diabetes and only one diabetologist. So they will not be able to deliver healthcare to everyone. Why not complementing this by using digital strategies? And why should modern diabetology not look like this in the future? I think we also should not fear this, but we should keep it in our hand and discuss it and give it a profile which is evidence-based and following our medical guidelines. And the International Diabetes Federation will be a facilitator in this process. I mentioned the fasting. This was only discussed at some spots at the ADA, but next week I'm in a conference in Morocco, and there are about 4,000 colleagues coming to discuss fasting and diabetes. And the International Diabetes Federation is currently developing a guideline for fasting and diabetes. We know eating less is healthy. We could say eating nothing for a certain time is maybe even more healthy, and it is. If you don't eat for 2 weeks, so not take any kilocalorie, after 4 days not eating anything, you are at low glucose and low insulin, and then glucagon is switched on, but the glycogen stores are also empty. And this is the right moment for glucagon to switch on beta oxidation of fatty acids. Now, it also could switch on breakdown of proteins, but if you are physically active, so walking 10,000 steps a day, it switches on the beta oxidation of fatty acid. And where? In the pancreas and the liver. And this is a way to remove fat out of the pancreas and the liver. And this is a place where the fat is the devil for our diabetes patient. So fasting is a fast and efficient way of improving health for people with diabetes, but anyone else who's having liver fat as well. And it's a total reset for the microbiome. And this is another cool aspect. And what is the reason? And this is shown here. You run into ketosis. And 10 days of ketosis, total ketosis, it's a fascinating experience. I always say the ketone bodies are like cocaine for the brain. So you feel fit, you feel strong, you are active, you are creative. So the idea of not eating and we die is wrong. Yeah, it takes 2 to 3 days to come into this phase, but then it's a cool experience. And here you see an AGP of a patient with diabetes after fasting, and you see he's having a flat glucose curve compared to the one lady I showed you at the beginning. So this is a cool new strategy for diabetes prevention and diabetes care. And here you see MR spectroscopy before the fasting of a type 2 diabetes patient. And all this cloudy spots is liver fat. And this is after fasting. And I think it does not need more explanation why fasting is efficient for people with diabetes if they have liver fat. How to do it? You stop eating, you have to empty your gut, you drink 3 to 4 liters of water or tea. From the first day you're on, from the 4th day you're on ketosis, and this is good. You should be physically active to the level than you have been before. And it's important how to break fasting after 2 weeks. Start after the first day with 600, then 800, 1,000, 1,200 kilocalorie. Then you can go to the normal lifestyle again, and you will benefit a lot because you have lost about 10 kilograms and you have totally removed your liver fat. And this is the current stage, what could be a recommendation, a guideline recommendation for fasting. This is what I just have shown you. And in, I think, June next year, the IDF will release a guideline for fasting and diabetes. And this is what on metabolic level can be achieved by fasting. I will become the next president of IDF, and I will focus on prevention, digitalization, and building a strong organization and addressing the need of the patient. This is where my passion is. The need varies in different countries, but every patient has the same right to get the same quality of care. And IDF should become a powerful voice in achieving this. And what I just meant, every patient has the same right to get the same quality of care and should have the same access to this quality of care. And there's still a lot to do, a lot to achieve. And I will focus on 3 things as president of IDF: being in the diary of every healthcare politician, being in the pocket of every diabetes patient, and being in the heart of every healthcare provider. And how? First will be a global diabetes index. So we will measure the quality of diabetes care in every country once every year. And we release this to free to all the politicians and every stakeholder who's interested in, with a goal to make them acting to improve the quality of care. Second, being in the pocket of every diabetes patient will be an app to deliver free diabetes education to anyone who has diabetes. And thirdly, being in the heart of every healthcare provider for me means to build a worldwide IDF fellowship program to invite every person who wants to treat people with diabetes to become fellow of the International Diabetes Federation. With these activities, after the ADA, we would like to work on, because we have a true understanding that people with diabetes deserve a better life, and the International Diabetes Federation will be the roof structure to bring you together, to work with you colleagues in India who are so active in the diabetes world, to improve the quality of care for people with diabetes worldwide. So let's work together with all our knowledge, our intuition, to help our people to walk away from diabetes. Namaste. Thank you very much for your attention.
Thank you. Thank you, Dr. Peter, for a nice and beautiful presentation. And hope our audience has actually got a lot of messages from this presentation. I know more than 4,000 people have logged in now today for today's this webinar. And yeah, so that is a great thing. And thank you, Dr. Peter. You stay with us. We'll have some discussion just after Dr. Agrawal talk. So stay with us, Dr. Peter, please. And Uma, please, could you please start the video?
Thank you, sir. So the technical team will now start a short video.
Yeah.
Thanks, everybody. Abhay sir, over to you.
Yeah. Thank you, Uma. Thank you. For our next topic will be, we'll have again planning from ADA, the CV protection, and that is that will be covered for with us. Dr. Sanjay Agrawal will discuss that thing with us, and we know Sanjay sir. Actually, everybody knows Sanjay sir. He's a very active member of RSSJ. Already is already he has been introduced by Dr. Amit. So I request Sanjay sir to start his presentation.
Thank you very much, Abhay and Amit, for giving me this opportunity to speak today on learnings from the ADA. But I would like to compliment Dr. Peter Schwartz for such a powerful statement that he made as a president-elect of the IDF. And I'm sure under his presidency, the world is going to see a huge stride in better management of diabetes. And probably our main concern about how people with diabetes are going to fare in the long term, I'm sure there will be a lot of important decisions that Peter is going to take, which will have long-lasting impact value. So I think his presentation sounds, or gives us thought of what he plans to do on the long term. And I compliment him for all the thoughts that he's got. Moving on to my own lecture, I would like to sort of talk something that was discussed during the ADA on cardiovascular protection. And whenever we talk about cardiovascular protection, we always start with lipid lowering as one of the most important area that we would like to concentrate on, because we know that there is a direct correlation between dyslipidemia and occurrence of cardiovascular event rates. Now, if you look at this slide, you can clearly make out that, just give me a second, I'm just trying to minimize this. All right, that LDL is one of the most important goals that we need to look at. And abnormal lipids increase the risk of cardiovascular disease. And, sorry. Okay. And we need to sort of see how best we can reduce the risk of myocardial infarction by reducing the lipids. And if you look at this InterHeart study, the InterHeart study looked at all the possible modifiable risk factors which could be responsible for the occurrences of myocardial infarction. And lipids stand out, one of the most important reasons for occurrences of cardiovascular disease, and followed by, of course, all of them differently. Now, another important conclusion of the InterHeart study was that if you sort of address each of these risk factors alone, would have far lesser impact value than addressing all of them together. So, I mean, InterHeart study was a very landmark trial which looked at a case control study of almost 15,000 patients with acute myocardial infarction, and they were matched against almost 14,000 controls, and this was conducted over 52 countries. And it has landmark sort of, conclusions, which has been sort of validated even today by different studies. So let us look at how does really LDL become a causal agent in ASCVD pathogenesis. And this data comes from various sources where we look at observational epidemiological study, the Mendelian randomization genetic analysis, various RCTs and animal experiments have sort of put the blame on LDL cholesterol. And obviously, when we put the blame on LDL cholesterol as one of the most important risk factor, then it becomes the primary target for our, therapeutic area, where how can we sort of lower the LDL goals? And some of the important questions that we need to answer is, how much LDL do we need to sort of get people to safer targets? So, reduction of LDL, is it supposed to be the same for all risk profiles? Or should there be sort of a differential LDL lowering depending on risk profiles of individuals? And accordingly, how much of LDL that we should reduce? And does a single agent really get you there, or should we use combination of agents which will help you to reach the LDL goal that we target out for? But there are three principles of LDL cholesterol lowering. The lower the better, the faster the better, the longer the better. Now, here's a sort of a slide which looks at the objective, and this comes from the 2022 ACC Expert Consensus Decision Pathway, where more than or equal to 50% reduction in LDL cholesterol and achievement risk-based LDL cholesterol thresholds. So we look at 3 patient population and then decide what should be our LDL goals and the non-HDL goals. So adults with ASCVD at a very high risk, including ASCVD with familial hypercholesterolemia, our LDL goal should be lower, less than 55, and non-HDL should be less than 85. Adults with ASCVD not at very high risk, that's about high risk, it should be less than 70 LDL, and non-HDL of less than 100. And adults without ASCVD, that's primary prevention, the LDL goal should be less than 100 and non-HDL goals of less than 130. But if you look at the Lipid Association of India guidelines, and this has also been quoted in different meetings, people at recurrent ASCVD risk and a very high risk, they're also looking at going all the way up to 30 LDL goals in order of CV protection. So it's kind of a very dynamic area as to how much of LDL reduction that you really need to look at. Now, this was published in the ADA Standards of Care in 2024, that in patients for primary prevention, patients who have diabetes between 40 to 75 years of age at a higher cardiovascular risk, including those with one or more ASCVD risk factors, it is recommended to use high-intensity statin therapy to reduce LDL cholesterol by more than or equal to 50% of the baseline, and to target LDL cholesterol goal to less than 70. And this has a level A recommendation. For secondary prevention, for people with diabetes and ASCVD, treatment with high-intensity statin therapy is recommended to target an LDL cholesterol goal of more than, or LDL cholesterol reduction of more than or equal to 50% from the baseline, and LDL cholesterol goal of less than 55. Addition of an ezetimibe or PCSK9 inhibitor with proven benefit in this population is recommended if the goal is not achieved on maximum tolerated statin therapy. So here you've got 2 sets of population, one for primary and one for secondary. And in the secondary prevention, you're trying to get lower goals, but obviously statin alone may not get you there. And you have to look at combination therapy with either an ezetimibe or a PCSK9. This has a level B recommendation. So if you look at this cartoon and you have various sites of action of lipid-lowering agents, you find the common agents that we are now targeting to get effective control are obviously time immemorial statins. Then you've got bempedoic acid, ezetimibe, and inclisiran, and PCSK9. So these are the 5 agents that we have got today, which are available in clinical practice, although inclisiran as of now is not available, but it's going to be introduced very shortly in India too. And you've got all these other 4 which have already been there. And we are going to look at how we can, what are the areas that you would use each of these agents. Now, in the Improve It trial, you can see here that ezetimibe, they looked at 2 sets of populations, patients with diabetes and without diabetes. And they looked at how effective is ezetimibe in reducing cardiovascular events. So they had 4 subgroups: patient without diabetes, one group on ezetimibe simvastatin, the other group on placebo plus simvastatin. And then, of course, you had a second group of patients with diabetes, and they were randomized into 2 groups, one with ezetimibe and simvastatin, and the other group was with diabetes and placebo or plus simvastatin. Clearly, you can see here on the forest plot that patients with diabetes did much better on ezetimibe than patients without diabetes. And if you look at all the primary and secondary endpoints, patients with diabetes had a far lower risk of cardiovascular events. And if you look at all the MACE events, they were lower in the patients with diabetes when ezetimibe was given. So in the Improve It study, the benefit of adding ezetimibe to statin was enhanced in patients with diabetes and in high-risk patients without diabetes. Okay. Now, bempedoic acid, they looked at it across all the glycemic spectrum. So they looked at 4-point MACE incidence, and this data comes from the Clear Outcomes trials. The trial enrolled about 6,000 odd patients, of which 45% had diabetes, the 41% had prediabetes, and about 12.9% had normal glycemia. So if we look at the hazard ratios of risk reduction, then clearly you're looking at 4 subgroups: overall, normal glycemia, patients with prediabetes, and diabetes. So you see here that the hazard ratio, there's almost about 17% reduction in patients with diabetes when bempedoic acid was used, for reduction of the 4-point MACE. And this was far superior, and this was the p-value significant in this group. Although in the other groups with normal glycemia and pre-diabetes, there was a tendency towards improvement, but this was not clinically significant. So the statistical benefit is only seen in patients with diabetes when you look at 4-point MACE reduction, and bempedoic acid is used across all the glycemic spectrum. So clearly you can see the case is very strong here. Whether you look at relative risk reduction or an absolute risk reduction, you find the benefit is larger in patients with diabetes as compared to non-diabetic population or pre-diabetic population when you're looking at a reduction in 4-point MACE. Again, if you look at the incidence and hazard ratios between bempedoic and placebo in patients with diabetes at baseline cardiovascular risk category. So patients who had 4-point MACE, the primary prevention, there was clearly a better reduction in the 4-point MACE with bempedoic acid as compared to placebo, and there was a 30% reduction. Again, secondary prevention, there was almost about 13% reduction that you can see in the group that received the bempedoic acid. If you look at outcomes for 3-point MACE, again, bempedoic acid for primary prevention, there was a 35% reduction. And for secondary prevention, there was a 14% reduction that you saw in the bempedoic acid group. But we know that the lessons come from the statin therapy of new onset of diabetes. So what happens, that does use of bempedoic acid worsen A1C, or does it lead to new onset diabetes? And this again data comes from the Clear Outcomes trial, where they looked at post randomization A1C, and you're looking at patients with no diabetes, that's basically a composite of normoglycemia and prediabetes. And you can see here that patients with normoglycemia and prediabetes, there was no change in the A1C that was there as compared to placebo. And this was at month 12. And then if you look at end of study, you found that there was no, again, increase in the rates of worsening of the HbA1c. Now, same thing, if you look at patients with new onset of diabetes, you're looking at normoglycemic pre-diabetic population and a composite of both when we call about no diabetes, you find that patients with bempedoic acid did not have any increase in the rates of new onset of diabetes. In the 4 years trial, they looked at efficacy of evolocumab by diabetes status. And in this study, they looked at patients with diabetes and no diabetes. And if you look at the cardiovascular risk and event rates, patients with diabetes, which had almost, in this trial, almost about 11,000 patients were enrolled, of which 40% had diabetes. You find that there is a 17% risk reduction for cardiovascular events in patients with diabetes and an absolute risk reduction of 2.7% as compared to patients without diabetes, where the relative risk reduction is 13% and the absolute risk reduction is 1.6%. So here you find again that even with evolocumab, the response rates with patients with diabetes was higher as compared to patients without diabetes, although both the groups had benefit and both of them had statistically significant reduction when you look at the p-value comparison. What about safety profile? And we look at again whether they had new onset of diabetes or did the glycemic control worsen over time in patients with evolocumab. And you find clearly that at the end of 1 year, 2 years, and 3 years, there was no increase in the new onset of diabetes, and the glycemic control did not worsen over a 168 weeks period of time. Inclisiran is, of course, a new kid on the block, and we still don't have it in India, but I am told that it's going to be very shortly introduced. And you're looking at the efficacy across the glycemic spectrum, where you're looking at normoglycemic and pre-diabetic patients, and then, of course, the diabetic patient. And you can see here that in patients who received the inclisiran as compared to patients without inclisiran, there was a difference in the percentage of change, which is almost about 46.8% in normoglycemic, 51% rates in lowering of the LDL cholesterol in patients with prediabetes, and almost about similar 52% reduction in the LDL goals in patients with diabetes. So the inclisiran patients had much better response across all the glycemic strata, right from normoglycemic levels to diabetes, although there was a marginal better reduction in patients with diabetes as compared to the other two groups. In the reduced trial, they look at icosapent ethyl in diabetes subgroup. And if you look at the primary composite endpoints and the key secondary endpoints, you find that you're looking at sort of 4 subgroups, placebo with total events, icosapent, and you look at all the total events that occurred, and first events with placebo and first events with icosapent ethyl. So they looked at first events and patients who received total and who had total event rates. And you find clearly that in patients with total events, there was almost a risk reduction of about 33% when icosapent was used. And in patients with first event rates, the reduction was close to about 33%. Again, similar reduction that you see out there. And even in the key secondary composite endpoints, you found that there was a very similar reduction of about 29% when you looked at total events. And if you look at reduction of first events, then in the icosapent, there was almost about a 30% risk reduction that you saw. So clearly, even icosapent ethyl had a reduction, and this data comes from the reduced trials. So if I have to make a conclusion for new lipid-lowering therapies, then you find that patients with diabetes have higher rates of MACE than persons without diabetes. LDL cholesterol, lower the better for CV outcomes and longer duration of therapy is better. Statin-treated patients continue to have ASCVD events despite LDL cholesterol reduction with statin monotherapy. Non-statin therapies provide the same risk reduction of LDL cholesterol reduction as statins and are recommended by both AHA/AC and European Society of Cardiology, as well as the ADA. And implementation in clinical practice lags far behind guidelines and evidence. And new approaches, including early initiation of combination therapy, are warranted to improve implementation. Adherence remains one of the great challenges in preventive cardiology in regards to both lifestyle changes and changes in the drug therapy, where new options are available to address this issue. I'm just going to quickly run through, because I've run out of time and I don't want to sort of spend more time. I'm just going to take 2 minutes on this. That there was another good study, the diabetes and cardiovascular disease, where they looked at ischemic preconditioning. And I'm just going to go straight to the conclusion in interest of time, where they said that if you sort of follow this flow diagram, then patients with diabetes and prevalent ASCVD start, SGLT2 inhibitors, Empower Cana, when you're looking at concurrent optimization, blood pressure, and LDL cholesterol along with lifestyle changes, or use GLP-1 RA, liraglutide, semaglutide. So either one of these two, and sort of you're going to look at it when patients are at a high risk for heart failure, you use an SGLT2. Patients that are high risk for ASCVD, you use a GLP-1. And then, of course, you follow with the other. And if both of them, you require an additional control in terms of glycemic lowering, then you can consider pioglitazone, or you can add any of the other agents as such. We need to also understand that in newly diagnosed patients, the time to incidence for diabetic complications can be very short. Earlier, we used to say that it takes about 8 to 10 years of time before the onset of diabetic complications, but this mean incidence time to diabetic complications is now reduced to 3 to 5 years, which means our screening for diabetic complications should start at the time of diagnosis and early enough, particularly in young onset of diabetes, because the earlier the onset of diabetes, it reduces life expectancy. And here's a graph that compares age of diagnosed diabetes to mortality. And you find that lower the age, the higher the mortality that happens. We are focusing now on a holistic approach for diabetes management. And obviously, we need to factor in all these things. Again, legacy effect can be sort of, we talk about occurrence of microvascular events, cardiovascular, and mortality. And the earlier glycemic control has been associated with lower rates of all these complications. Does use of SGLT2 inhibitors mitigate this? You find that if you have about 2 years of exposure in the first 2 years of diagnosis, then it ameliorates the legacy effect. But when you start this drug late, it perhaps has no significant benefit as compared to starting alone. So we need to sort of start these disease-modifying agents earlier and independent of the glycemic control. Again, multiple risk factor control we need to do early, and this is from the follow-up of STENO2 study. I just want to say that early combination therapies are the order of the day, because the time to failure of the study gets longer, and obviously time to escalate the treatment or time to insulin therapy is prolonged if you start earlier combination therapy and get your patients to goal quickly. And this data comes from the Verify study. Remember that for most patients, we require lifestyle, metformin, and disease-modifying therapy, along with, of course, teamwork, patient empowerment, and shared decision-making. So, it depends on the risk profile that patient carries. If you have patients with high risk for heart failure, CKD, or ACVD, combination of SGLT2 with metformin is great. Patients at the risk for ACVD, GLP-1 with metformin, and obese patients, SGLT2 with GLP-1 are a great combination. We are seeing a whole bit of new agents that are coming into the market, which not only aim at weight reduction, but also aim for glycemic controls. And today we talk about how much of percentage of weight reduction that we require for various endpoints, whether it's glycemic control, prevention, dyslipidemia, cardiovascular risk reduction, or remission of type 2 diabetes. And these are just a summary of all the agents that are available today. So I just want to end up and say that we are in a very exciting time today. And obviously, we need to make wise choices in our patients if we want to see that, we are able to get them to goals quickly and we are able to manage our patients more effectively.
Thank you, Sanjay sir, for a beautiful presentation, and nicely you have discussed how the lipid lowering agents are important and how we are going it combination therapy, and how anti-diabetic drugs, what are the best available options with us for management of diabetes. Before going for discussion, I'll request Uma for a small 2 minutes break, then we'll have a small discussion. Uma, please.
Thank you, sir. Can I now ask the technical team to play the video?
iCan, your new continuous glucose monitoring system for all people with diabetes. Easy to apply and comfortable to wear. Real-time glucose monitoring, continuous 3-minute connectivity. Every time iCan. Forget about the unawareness of hypo and hyperglycemia and pain of finger pricks. Forget about interference from vitamin C. Forget about worries about water when you're bathing or even surfing. iCan is water resistant to 8 feet for 2 hours. iCan has a 15-day wear life. With iCan CGM app, you can check your blood glucose anytime and anywhere. With iCan Reach app, you can share your data with loved ones. iCan makes managing diabetes easier so that you can enjoy activities of daily living effortlessly. Set your own alerts for low and high glucose levels. No worries, even at bedtime. iCan provides real-life accuracy. iCan empowers you with self-management. Your choice, iCan. SanoCare, caring for love.
Thank you, Uma. Now request Dr. Peter and Dr. Sanjay Agrawal will have a discussion. Is there any questions, Uma, from the audience? So before going to the audience question, I would ask Dr. Peter. So, sir, when this 14 days fasting, when a diabetic will do, what will be the treatment plan during that 14 days of time?
Very good question. I didn't elaborate on it, but strictly spoken, you can stop all medication on the first day of fasting. And this is also the procedure. I do it and many colleagues are doing. So you stop any medication, and then you take a minute to reconsider what kind of medication is maybe needed. For example, in a cardiovascular patient, the anticoagulants. In the past, I also said antidepressant you should give further, but the psychologist told me, there's no need. Doing fasting is such an antidepressive procedure. But for example, thyroxine, I would go on to give. So, but the procedure, and it will be probably also as is in the guideline to say you stop any metabolic related medication, that means blood pressure, lipids, glucose, in a patient with type 2 diabetes during the fasting. And 3 weeks after he finished fasting, you reconsider what kind of medication you still need. So don't start immediately after fasting, take 3 weeks and then you reconsider it.
Yeah. Thank you, Peter. And another question is, what will be your thought about diabetes and keto diet?
Diabetes and what?
Keto diet.
Keto diet. Also a very good question. At the end, fasting is the same like ketogenic diet. Because in a ketogenic diet, you eat the fat you are using for energy metabolism. In a fasting, you use the fat you have stored in your body for energy metabolism. The effects are very similar, but I would say I'm lazy. Why should I eat the fat if I have it in my body and I can benefit much more during fasting? But the ketogenic diet is a good procedure to go ahead after fasting. But I recommend my patient, you can do low carb, you can do very low carb, you can do ketogenic, you can do intermittent fasting. It doesn't matter. You should find the way which fits in your daily life best. But once a year or once every 2 years, you should do the total fasting with water diet for 2 weeks.
Good. Thank you. And Dr. Sanjay sir, is there any difference of LDL goal for Western people and Indian people? Because we know Indian people have much more higher risk of cardiovascular disease in comparison to the Western population. So is there any cutoff of lower cutoff for LDL goal target for Indian population or Asian population?
I think if you look at the Lipid Association of India guidelines, we have very similar cutoffs that we have used, as compared to Caucasian. Only thing what they really talk about is going extremely low, in very high risk populations. As I said in the talk, that they've also recommended going all the way up to 30 and 50 in very high risk, particularly patients who've got a very aggressive atherosclerosis. Most of the Western guidelines have not reached the recommendations of 30. They stop short at about 50. But in our populations, we have seen the benefits up to 30 if you can safely achieve them. But the important part is, of course, that get to your goals, reduce the risk, and get them effectively with minimum side effects of the medication that you can use. There is no single drug that can get you to very low levels. So don't try and up-titrate statins to very high doses, particularly in the Indian population, because you may stand a risk. Using combination therapies of lipid-lowering agents probably are much safer and more effective than using single agents at very high doses.
Yeah, actually, suppose you have reached the highest level of either rosuvastatin or atorvastatin, still your LDL goal you have not achieved, and patient is actually quite poor, cannot use PCSK9. So what will be your thought at that time?
Yeah, so we've now got, of course, patients who are on, let's say, high-dose statins. You can combine them with either ezetimibe, or you can combine them with bempedoic acid, or you can sort of use a combination of all three. You can use bempedoic acid, ezetimibe, and a statin therapy. Of course, for most of our population, PCSK9 or inclisiran are out of reach because of the extremely high cost that we tend to have. But never ever forget the role of lifestyle modification, because you need to ensure that people with dyslipidemia follow a very aggressive lifestyle modification in terms of diet and exercise, weight reduction, and perhaps, that is going to benefit a lot along with all the pharmacotherapy that we may give the patient.
Yeah. Another most important thing, what is your thought process about triglycerides during the management of this LDL goal or during this management of dyslipidemia? What is your thought about triglyceride?
So I think, that's a good question, because if you ask a cardiologist triglycerides, he is not very happy. I mean, he's not really too concerned about triglycerides. But if you ask any metabolic physician, diabetologist, for him, triglycerides becomes a very important goal to achieve, because we know that triglycerides have many important correlates that we talk about. Besides the fact that there is a cardiovascular risk that it carries, a very high triglyceride, the risk for pancreatitis becomes high. But it's also been shown that, as a marker for primordial prevention of diabetes, triglycerides elevation is one of the important markers for patients who are going to be destined to develop prediabetes or diabetes. Secondly, it's like a fat that spills over from the adipose tissue and goes into ectopic space. So high triglycerides can get deposited into the liver and may be responsible for fatty liver, and deposit into the pancreas to cause reduction in the insulin secretion. So triglycerides are an important component. They multiply the cardiovascular risk effects of LDL. And, if you look at if you have somebody who's sort of achieved an LDL goal, their cardiovascular risk does not become completely eliminated unless you can get the non-HDL goal also down, and which is why we talk about non-HDL and LDL. And one of the most important components of non-HDL is triglycerides. So you need to see that you need to achieve a triglyceride lowering along with LDL goals.
Yeah. Thank you, sir. Dr. Peter, could you please elaborate something like that? That is a concept that in diabetes, if you are giving insulin before going to any OHA for a short duration, then probably a lot of the time people undergo remission. What is your thought about that part?
I must apologize. I didn't fully understood the question.
That those newly detected type 2 diabetic patients, if you put on insulin from the beginning, even if without before OHA, then there is a chance of reversal, or there is a chance of remission for a short time. What is your thought about that?
So this is a controversy going on about early insulin treatment. There are arguments pro and con. First, you don't reach diabetes remission by giving insulin, because diabetes remission is something completely different in definition. You have normal glucose value and you don't require additional insulin. There are arguments to normalize glycemia fast with insulin in some, especially the Western world. If you talk in reducing cardiovascular risk in someone who is having a high glycemic level, he will benefit from it. But the most natural way, and this is changing a little bit with the GLP-1 story coming up now. But I will not warn, but the GLP-1s and the twincretins and the triple agonists, these are very cool drugs and they are very efficient and they help the patient. But they are very expensive and they only are efficient as long as you take them. If you stop using the drugs, you gain weight again. So we are talking about a lifelong expensive therapy and we should look for alternatives. And with the GLP-1s, the need for early insulination goes away. And I actually would propose that diabetes remission is a very interesting topic. But before we talk about insulin, I would give these people a sensor. So using sensor-based interviewing or the sensor-based interventions to help them to change lifestyle. And I would try fasting. And I think in 40% of the cases of newly diagnosed diabetes, combining fasting with a sensor, we can reach a diabetes remission, and then the need for giving insulin is going down and down and down.
Yeah, thank you, sir. It's a thank you. Today you have a beautiful discussion in collaboration of Diabetes India. Today, more than 4,200 people have logged in today for today's webinar. And thank you all our panelists, and thank you the whole team, and thank you Dr. A.K. Azad Khan sir, Dr. S.R. Arvind sir, and Dr. Vanshi Shabu. And thank you for today's our panelists, Dr. Peter Schwartz and Dr. Sanjay Agrawal. And thank you my co-chairs, Dr. Amit Gupta and Dr. Sanjay Reddy. And the most important part, thank you all our viewers, all our physicians, 4,200 physicians who have today logged in for today's webinar. And Diabetes India is going to do a lot of such activities in future. And with this much, I think I hand over to Uma for final vote of the thanks.
Thank you. Thank you very much, Abe.
Yeah, thank you also
sir.
from my side. Thank you to all the attendees to come to this late time and to listen. This is very cool and important.
Thank you.
Thank you. Thanks everybody for joining today.
Yeah, thank you. Yeah.
Ciao.